I'm starting.
Yeah, please.
Good afternoon, everyone present here. I am Faraz from Clarnet. Clarnet is very proud to be a part of this session as a digital partner. Clarnet is India's digital live semi platform where doctors generate medical content. And with you all, I am presenting a short video on Clarnet. Thank you so much all doctors for watching the video, and you all are requested to visit our website www.clarnet.com, where you can watch lots of live sessions conducted by expert doctors across the globe. And we have MedWiki services, which is medical Wikipedia for doctors only that you can read. By taking not much time, I would like to hand over this session to Dr. Nehal Patel, ma'am. Over to you, ma'am. Kindly proceed from here.
Thank you, Faraz. Thank you, Clarnet, for providing us a great platform for e-learning. I thank all my team AOP, especially Dr. Rakesh Desai, President AOP Gujarat, and Dr. Kirit Sisodia, Secretary AOP Gujarat, for this wonderful session which is ongoing. I also thank Dr. Yogesh Parikh, who is project in charge of this session. Today, for the case of newborn, we have Dr. Gunjali Shah as the case presenter from MP Shah Medical College and GG Hospital, Jamnagar. Her mentor, Dr. Maulik Shah, is a well-known pediatrician and also a YouTube sensation. Sir is an associate professor at MP Shah Medical College and GG Hospital, Jamnagar. He has many other learning sessions available on media for general public also, and very nice program which was very much well known is Guj Mom. I welcome Dr. Maulik Shah, sir. So for today's case presentation, we have two renowned experts, Dr. Somshekhar Nimbalkar, sir. Sir is a professor and head at neonatology in Karamsad Medical College. Sir is a national coordinator of IAP NNF NRP program since last 3 years. He is an honorary secretary of KMC Foundation of India and chairperson elect 2022 for IAP Medical Education chapter. He has many papers in his hand, and almost more than 120 PubMed index publications and 250 plus international research presentations. So I don't even think that I can anyway touch sir at any point of time. So I welcome you, sir. We have another one, a star.
I think Dr. Nehal has lost the connection.
Ma'am, you are not audible to us, ma'am. I think there is some issue with the network.
I'm so sorry, my connection was lost. Am I audible now?
Yes, yes.
Yeah, so we have another stalwart as an expert today, and Naveen Jain sir. Sir is a senior consultant in KIMS Health at Trivandrum. Books we all PGs have read for neonatology in our residency. Challenge these two books. Sir is editor in them. One of them is Illingworth Textbook of Child Development, and another is Cloharty Manual of Neonatology. So I welcome you, sir, also, please. And Dr. Baldev Prajapati, sir, who is the convener for this program. Sir doesn't need any introduction, and whatever I say, the words will be laced for him. Sir has a great passion for teaching, and one of them is the thing that this program is successful. Thank you, sir. I hand over to you.
Good evening, friends. Welcome to this our Saturday PG clinic. Just for the information to the friends that what will be the flow of our discussion. I came to know Dr. Gunjali from MP Shah Medical College is the presenter. So she will share her PPT and start with the history part. I think there are some students also, and I request them that participate very actively in the discussion. Whatever comes to your mind, any question, query, you can. And I'm sure that with this history part, we'll go for the discussion with the students, then the final word from the experts. And then we'll go for the examination, last investigation, whatever they have performed. And we'll try to learn the condition, whatever at last comes with the diagnosis. And more details we'll get from the experts, Dr. Somsekhar and Dr. Naveen Jain. I'm very happy to get even both the experts very close to me, and I know both of them since many years. And as Nehal said, I think in the subject of the neonatology, both are definitely, nobody else can be better than these two experts. With these remarks, and of course, Dr. Maulik, very nice to see you on the screen after the long time. All of us know, very active, dynamic pediatrician from Jamnagar. And he's, I will say, has taken also the very good challenge to educate the people on the various aspects, particularly the current issues. And definitely it's a very good, I will say, activity, and very successful he's managing. I think technically he's good. Therefore, even in the social media, he is able to put the format the way in which he wants. So I'm sure that with all these, his, I will say, ability, the presenter must have got the maximum benefits. With this remark, let me request Dr. Gunjali to share her PPT and start the history part. Dr. Gunjali, please.
Yes, sir. Good evening, everyone. Am I audible, sir?
Yes, yes.
Yes,
And
you are audible.
PPT is also nicely seen full screen.
Okay, sir. Good evening, everyone. I would like to thank everyone for giving me such an opportunity to present this case. I would like to start from the history portion. Baby of S, a female child, resident of Jamnagar, born of non-consanguineous marriage, comes at first hour of life with complaint of prematurity, low birth weight, and fast breathing since birth. So the present age of the child is 15 days of life. Hospital course, preterm 32-weeker, born on 20th August 2022 at 2:39 p.m. by normal vaginal delivery with birth weight of 1,500 grams at GGH Jamnagar. On admission to the NICU, the baby had signs of respiratory distress, suggesting the Silverman-Anderson score of around 5/10. The baby was kept on the non-invasive ventilator support, that is on the CPAP, with PEEP 5 and FiO2 of 30%, and feeding with the formula milk was started via the rice tube through the mouth. After that, the baby still had the signs of distress with the same Silverman-Anderson scoring, and the baby was on CPAP, so the exogenous surfactant was introduced. The RBS monitoring was done while the baby was in the NICU. The blood reports were done, which came out to be normal. Urine stool were passed within 24 hours after birth. When the EBM was available, the baby was fed with the same. At 36 hours of life, the baby developed yellowish discoloration of the skin and the sclera, for which the baby was kept under the phototherapy lights. Gradually, the distress was reduced, and at 48 hours of life, the patient was shifted to the nasal pumps. Gradually, the spoon feeding was introduced, and the baby was kept in skin-to-skin contact to the mother and was shifted to the KMC ward. Then gradually, the breastfeeding was introduced. Supplements were started after 8th day of life. Today, the baby is 15 days of life with a weight of 1,450 grams, and the baby is on breastfeeding plus spoon feeding with the EBM. Antenatal history. The mother is 23 years old. Mother is a registered case at Anganwadi. Gravida 2, Para 1, Abortion 1, and Live Birth 1. The Gravida 1 was a spontaneous first trimester abortion before around nine months. Gravida 2 was a spontaneous conception, and the pregnancy was confirmed by the urine pregnancy test. The mother had taken around 4 to 5 antenatal visits. The pre-pregnancy weight was around 42 kgs, and total 8 kg weight gain was found during pregnancy. So the first trimester history, the mother had no complaint of fever or rash or vomiting, or no history of hypertension or diabetes, no history of exposure to the drugs or radiation, history of blood transfusion in the second month in the pregnancy, and the USG scan done during the first trimester were normal. Second and third trimester, the quickening was felt at around 4 months of amenorrhea. The ISA and calcium tablets were taken and were continued throughout the pregnancy, starting from the second trimester. The 2 TD injections were taken. There is no history of PIH or GDM or burning micturition in the mother. And the USG scans which were done during the second and third trimester, they were normal. The natal and the postnatal history. The mother had the history of leaking per vaginum since 10 hours with a spontaneous onset of labor pain. So the 1 dose of betamethasone was given to the mother. After that, the baby was delivered normal vaginally. So baby cried after birth and the birth was uneventful. And after that, the baby was handed over to the pediatrician. Coming to the family history, the mother and father, they are both educated up to high school level. Mother is 23 years old and father is 26 years old. Non-consanguineous marriage. According to the modified Kupuswamy classification, there is lower module socioeconomic class, and there is no history of blood transfusion in the family. The mother is having history of abortion before 9 months. At 2 months of gestation. Coming to the summary, the 15 days old female child born at 32 weeks gestation by normal vaginal delivery with birth weight of 1500 grams, which is appropriate for the gestation age. The baby cried immediately after birth and developed respiratory distress, which improved after giving birth.
Can you stop sharing?
Yes, sir. Yes, sir.
I think Dr. Gunjali is kind enough to give the details of the history. But you know, it's not so simple when you approach the patient.
Yes.
She has given here the title also respiratory, but not necessarily every time the child presents with you with the breathlessness is having the respiratory problem. May I know exactly how many students are there on the screen? We are fortunate to have you the good faculties also. Dr. Kruti Shah is there. Dr. Mehul Gosai is there. Can you just introduce the students themselves so that I come to know exactly, please?
Sir, myself, Kailash
because everybody's name is not seen. Sorry. Yes, please.
Sir, myself, Kailash Chopra. I am third year pediatric resident at MP Medical College, Jamnagar.
Fine. Dr. Kailash.
So myself, Dr. Agnes Joy. I'm a third year resident at MP Medical College.
Can you repeat? Sorry.
Myself, Dr. Agnes Joy.
Okay.
I'm a third year resident at MP Medical.
Right. Fine. I think Dr. Kailash, let us start from you.
Yes, sir.
Any question or query for Dr. Gunjali, whatever she has presented? Probably where you may feel some more information or you have some query or you need some clarification.
Sir, those of beta was given, which was before how much time of delivery?
I think Kailash, you are having the two modes, laptop and mobile or something, or two friends are together. Something is there. So echo is issue.
Yes, sir.
I think all three residents have sat in same.
Okay,
can you separate yourselves from each other?
Yeah.
Physically separate, different rooms. Preferred.
Yeah, in different rooms, please.
Because otherwise what will happen that your voice will not be clear.
Yeah,
Echo will be
there.
interfering to us. Anyway, I think till they manage, Dr. Gunjali, you can take. Suppose you are the first person on the call and you get this baby with the breathlessness, probably maturity, everything you may not be aware, but they just delivered the baby and baby is breathless. Dr. Kailas, then what things will come to your mind? Common, I will say, conditions.
Yes, sir.
Baby is already delivered. You are on call and you are called to see the baby and you find that the baby is having the respiratory distress. Not necessarily even preterm. Or even you can divide that. Suppose baby is preterm, full term, what can be the various conditions which will come to your mind? I think again he has some problem of NAT. Jali, are you available? I think there is also some problem of NAT on their side.
Gunjali, I think is.
Yeah, now I think Dr. Gunjali has joined.
Yes, sir.
Dr. Gunjali, I hope that you have heard the question that immediately after the birth, if any baby is found with a respiratory distress, which common conditions will come to your mind?
Sir, immediately after birth, if it can be, sir, according to the gestational age. Sir, if the baby is a preterm child,
I think for your easy discussion, you can take even the maturity, you can take even the timing of the onset of the breathlessness also, respiratory distress also, so that you can have some clarity of the conditions.
Hello, sir.
Yes, sir. Gunjali, go on. I think between some net issues there.
So any student in the platform can answer the question. Please go ahead.
Gunjali, unmute yourself.
Yes, sir. Sir, am I audible now?
Yes, yes, audible. I think all of them are finding some difficulty of NAT. Between they are able to connect. Yes, Gunjali, you can take it further.
Yes, sir. So, sir, when the baby is born and if the baby is having respiratory distress, sir, if the baby is a preterm child, so sir, most likely the cause is RDS, respiratory distress syndrome. Sir, the second cause in the preterm can be, sir, if the baby is having congenital pneumonia. But sir, in that case, the baby will develop distress after a few hours of birth. In late preterm and term child, sir, the cause of distress can be, sir, transient tachypnea of newborn. And if the baby is post-term or at the, sir, the other cause can be meconium aspiration syndrome.
Okay.
Then, sir, the main causes of distress at birth, sir, these are the four main causes.
Anybody can define exactly that what we mean by the respiratory distress in the newborn? Dr. Kailas, can you take it?
Yes, sir. We clinically can say that a patient with respiratory distress have a subcostal, suprasternal, and xiphoid reflection with nasal flaring and audible grunting that we measure, calculated as a Silverman-Anderson score.
Before that, anything very important point?
So respiratory rate.
Tachypnea.
First tachypnea. And in the newborn, what is the cutoff value for the tachypnea?
Sir, if it is more than 60 per minute, then sir, it is considered as tachypnea.
So I think, in any
More than
age group
60 per
children,
minute.
yeah, in any age group children, for increased work of breathing, what commonly we say, or respiratory distress, number one is the tachypnea. And tachypnea, at different ages, different cutoff values that we should remember. For newborn, of course, more than 60, then the different endroins, right? That will also give the idea that respiratory distress is there. Maybe subcostal, maybe even intercostal, maybe suprasternal, and even every site of indrawing also will give some idea regarding some cause also. And sounds, different sounds. Particularly, I think in the preterm baby or this newborn, to get the grunt, which is the most common sound. Anybody can explain that what is exactly we mean by the, sorry, third person, I think Dr. John, am I right? Third resident from MP Shah.
So, Doctor.
Sorry,
Because Agnes.
Anyway, I think can you just explain that exactly what we mean by the grunt, or what is the mechanism and what is its significance? As a
Sir,
clinician, why we are very keen
sir,
to.
grunting.
Yes. Please go ahead.
Grunting, we can say that it's generated because of expiration against a partially closed glottis. It's like to create increase the negative pressure, so that can help in distending the alveoli in the premature infants.
Okay, I think again there is some problem of echo on your side, but okay. Dr. Kailas, can you explain exactly that why the baby is doing like this? She said that the forceful expiration again gives some partial close epiglottis. Why the baby is trying to, what actually baby wants to manage?
To maintain oxygenation, the child should expand the alveoli so that oxygenation and perfusion are measured. So for that, by expiring against closed glottis, the alveoli will extend and the functional residual volume will increase by that.
Exactly what happens in a case of RDS. Suppose if you are talking of RDS, which is a very common condition where you get the grunting. So exactly what happens?
Sir, in grunting, we can say the child is trying to create a negative, increasing the negative airway pressure within the lungs.
Why it is required?
Because, sir, the distending capacity of the alveoli is lost, that results in atelectasis of the lungs.
Right.
So for that, the child has to increase the pressure. So grunting is a compensatory mechanism, we can say.
Right. Anyway, I think that's important for us to understand that that even during the phase of expiration also, alveoli should remain inflated. They should not get deflated. And for that reason, negative thoracic pressure is very important. And somehow in this condition, it is lost. And therefore the alveoli remain deflated. And very rightly Kailash said, then there is the perfusion mismatch will happen. And to maintain it, to maintain the alveoli inflated, baby is trying to create the negative pressure by expiration against the partial closed epiglottis. And during that, whatever the sound is produced, which is very classical grunting. And why I will say is very important for the clinician, it's a serious condition. It is indicating to us that we should go for proper management of the baby. Right? I think that's ultimately we are interested to know all these signs, so that as a clinically you can define that what is the problem, and then further you can plan the investigation or management. Anyway, that is one aspect. But suppose it is due to some cardiac condition, but cardiac condition will also cause this breathlessness. Kailash, what is your idea?
Yes, sir. Cardiac condition.
Number one, I think you can take in this way, that what are the common cardiac conditions in the newborn where the baby may present with this distress, respiratory distress. And is there any peculiarity of these respiratory distress or any timing or anything? Can you take some common conditions?
Cardiac conditions are
Is there any cardiac condition in the newborn presenting as the respiratory distress, or there is no any condition in the newborn? They present later on. What is your idea?
so hemodynamically significant PDA will presented with distress and not maintaining saturation.
Okay. Any
Then
other?
persistent pulmonary hypertension, that's something else.
Okay, very good. Ultimately, we learn from the experts, but let us try to, I will say, by the interactions, we can learn in a better way. That's why I'm trying that the student should speak first. So, persistent pulmonary hypertension, yes. PDA.
Total anomalous TAPVC, sir.
Whether they will present in the first 24 hours?
Sir, within 1 to 2 days, if TAPVC is present due to excessive pulmonary congestion, the child can present with distress.
Okay. I will say, why not due to the birth asphyxia? So how will you differentiate that it is due to birth asphyxia? Because birth asphyxia can also cause the respiratory distress.
Sir, it will be acidotic breathing.
Okay, but how I will come to it is acidotic breathing, and it is not due to this lung problem.
Sir, we can find it out through clinical examinations or auscultation on the chest, and the baby will be having history of parental asphyxia.
Gunjali, on auscultation, what you are going to get on chest?
Sir, RS could be clear, sir.
And otherwise also RS is going to be clear in the newborn.
Yes, sir.
Right.
But sir, there would be a history of
I'm sure that suppose the transient tachypnea of newborn, even the hyaline membrane disease, yes, even the acidosis, many times even the subtle cardiac conditions, every conditions you are going to get the chest clear. As in the older children, you are going to get some erythrodemenis or wheezing or something, or even the crepitations in pneumonia. I think hardly we get these signs in the newborn, right? And that's why in the newborn it's very difficult to differentiate on clinical examination. But still, some points are there. Can you take it that how acidotic breathing you can differentiate from some other situations?
The acidotic breathing will be deep and fast, of course. Because it is acidotic breathing, sir, it will be deep, and even the baby can be lethargic if the CNS is affected due to the metabolic acidosis.
I think Gunjali, number one, what Nehal suggested, to avoid this echo problem, probably in your sitting arrangement, we'll have to make some changes.
So I would suggest one thing.
I think Dr. Somsekar is the expert to suggest.
I would suggest one thing. If you're sitting in the same room, when one person is talking, you just go to that, don't mute, go to that mute upper button and you say leave computer audio, leave phone. I think Kailash and this Gunjali are on the computer. You can just leave computer audio. So the moment you leave computer audio, when the third person is speaking, you will not get any echo. Same thing. So the remaining two people should leave computer, and then when that person starts speaking, you want to start speaking, you join again. That would kind of sort out that problem.
Yeah, I think, and I'm sure that technically you are better people. Thank you. So you can manage. Anyway,
sir,
simply.
Another thing is, sir, when one person is logged in from two devices, mostly it happens one is from mobile, another is from laptop, then echo came. One person has to log in from only one device. That echo issue will be resolved.
Yeah, I think that they have managed. Yeah. Yes. Thank you, Dr. Mayo. Nice to see you.
Thank you, sir.
Just Agnes, when Gunjali is speaking, please switch off your mic. That will solve the issue.
Yeah.
Yes, sir.
Anyway, I think so many things we are learning, not only the pediatrics or the newborn, that all these issues are going to be there with these, I will say, modalities and how to operate even in a better way. This is good thing. Anyway, the acidosis simply very easy. The respiration rate is high, but the chest is silent, may not be the introing at all, even hardly the sound. even not only in newborns, in older children also, how we are getting the diabetic ketoacidosis, right? So I think these are some points which you can keep in mind. At different ages, when the newborn also different conditions, respiratory, cardiovascular, some neurological, when conditions, when some neurological conditions can also present with this. So I think let us take expert opinion to learn. Dr. Somsekar, can you take it? That
Yeah.
this respiratory distress in the newborn, how at least we can keep the common conditions at different ages, even in the newborn also. So generally you can take the approach, so that I think it will be useful to us in our daily practice.
Right. So one of the most, so it is of course the most commonest one, as they have said. And given the fact that the baby is 32 weeks old, preterm, low birth weight, and so one of the most common indications would be respiratory distress syndrome. If it is a larger baby, term baby, and all, then you would have a lot of other conditions that you would want to consider. That, and so congenital pneumonia is a cold, close enough differential diagnosis even in the preterm. So those two are the most commonest ones that you choose. As the baby is bigger or the baby is term, then you would have other conditions that were already mentioned. Actually, I wanted to ask a few questions before to the causes as to the history, and I was interested to know that you said betamethasone was given, 1 dose of betamethasone was given. Now, I want to know from, say, Kailash, what is the ideal drug of choice for giving antenatal steroids, and what is the dosing strategy for antenatal steroids? So, Kailash, maybe you can answer.
Sir, betamethasone 12 mg, 12 hour apart can be given IM before 24 hour of the delivery, or dexamethasone 6 mg for 4 times 6 times given 4 hour 6 hourly apart at 4 dose, just 24 hour before at least delivery. And if not possible, then in emergency we can give also 1 dose, whatever possible.
So my question is, what does the government of India recommend between betamethasone and dexamethasone, which is the most more preferable kind of steroid that needs to be given?
Betamethasone.
Okay. So anyone else has a different opinion, Gunjali or Agnes?
Sir, dexamethasone is preferred more over betamethasone.
So any reason?
Because it is cost effective also, and also studies have proven that it reduces the chances of RDS more than the betamethasone.
Okay, Agnes, would you have any opinion on that?
Yes, one of the main reason in our government strategy that we are preferring Dexa is because of the cost effective, but yet we do not have any like a study proving that both the efficacy has been found to be similar, but due to cost effectiveness, we are rather preferring Dexa.
Okay, the in 2014, Government of India came out with guidelines which said dexamethasone should be preferred in India. So globally, everywhere betamethasone is used, but the salt which was used for the betamethasone for the studies, that particular salt is not available in India. And if we want to use the salt which is available in India, the dosing of betamethasone increases significantly, and then it loses the advantages it has over dexamethasone. So we prefer using dexamethasone in India, and at the dosing which is recommended. So in India, for all practical purposes, dexamethasone is supposed to be used. And of course, there's a cost advantage which is there. The main reason is the salt which is used in trials is not available in India. So that's one, and second is the cost. So that's one question.
But I think, Dr. Somsekar, one question from me: why globally they prefer this betamethasone? Suppose if you are able to prefer that salt.
So it has slightly better advantages in terms of side effects and stuff like that. So even there, and it is like dosing is lesser. It's like 12 hours apart, so that is a dosing advantage too.
I think at least what I remember, the things which we were taught many years back, that among these two, betamethasone is having the better receptor maturity compared to the Dexona from the effect point of view. It was considered. I'm not sure that whether it's the same reason they have given at present also. But later on, I learned that from the NNF only that due to the several regions in our country, we go for the dexamethasone.
Yeah, so Government of India came out with guidelines in 2014. And so dexamethasone has other side effects. I don't think it's a receptor, but there are other effects. So studies have shown that betamethasone is better abroad. But for us, I think it is dexamethasone. Plus the cheapness and wide availability of it makes it quite useful. So there's a Government of India guideline on usage of antenatal steroids freely available on the Ministry of Health and Family Welfare website, which you should download and read because it gives very specific instructions on how to use and why we need to use dexamethasone. So that was one question I had. Then second question
I think with that reference, Dr. Somsekar, again, suppose if you have planned, if you are given the dexamethasone properly as per the schedule, and still she had not delivered, and still there are chances of prematurity, is there a recommendation to repeat the dose?
No, previously a lot of people used to give, but now it is no longer recommended.
So now this repetition is not required. Yeah.
So then because multiple doses of dexamethasone or betamethasone also have shown that it increases poor neurodevelopmental outcomes.
Right.
And there is an interesting fact, I will not go into details, but around 20 to 32 weeks of gestation, because we have prematurity going on from 24 weeks onwards, like when we want to give steroids till 36 weeks or whatever, 34 weeks. Now between this, the receptors in the brain or the way in which brain receptors respond to steroids in the fetus changes between 20 to 32 weeks. So what becomes is a kind of a a negative connotation or I can't get the correct word, but what is it? Antagonist and protagonist. So those the same drug will cause a different reaction before 30 weeks and after 30 weeks. So at some gestation that the steroid will have a different reaction based upon the week. So it's a very interesting. There's a full detailed clinics in perinatology published about 3-4 years back, but let's not go into that. The whole point is the drugs react with our neural tissue differently, depends upon gestation. Now coming to other point which I want to ask, you mentioned that this pregnancy is the second pregnancy and baby delivered within 9 months after the first baby that was born. So my question is, and you said that 2 tetanus toxoid injections were given. So is that appropriate? Is it not appropriate?
Sir, the mother was not vaccinated during the first conception. So, sir, it is. So that's why the 2 doses have been given, sir.
Okay, good. So that's then, because if those 2 doses given in the initial pregnancy, then I think for at least a period of 3 years, there's no need to
3 years booster doses, yes.
And suppose cost is not the issue. Any other better preparation is recommended rather than TD?
So question is not for me. Question is for all 3 of you.
Yeah. Naturally, not for sir.
I will answer, but let them answer first.
Yeah. Naturally, on the contrary, if I find the difficulty, I will have to ask him. But this is very important in practice point of view. That suppose even your own some relative is pregnant lady, and she is asking that my obstetrician has advised me that rather than TD, you go to some another injection, and then she will ask you that is it so?
You mentioned red TD. You mentioned TD. You are asking.
T small d you mentioned, but I will say one more better preparation. Of course, in government security is not available. It is little bit costly. So probably it may not be in the government schedule, but yes, private practice it is available, and one should even practice. It is recommended. Which one?
Yeah.
And what is the explanation? What is the reason for that choice? Any student? Kailash, are you aware?
You are muted, Kailash. Yeah, please go ahead.
Yes, sir, but I don't know that.
I think it is not only for this pregnancy. This vaccine is routine for your pediatric practice also. So I think it's not so that it's specific for the pregnant lady. That vaccine which is used during this pregnancy which I am talking should be used in our pediatric practice also for the children. It's not, I will say, very specific vaccine. Is it? Nobody knows. Have you heard the TDAP?
Yes, sir.
Yes, sir.
Now, should we go for the TDAP in this pregnant lady? Suppose cost is not the issue for her. She says that's whatever best, I'm ready to accept it. Then TDAP. Why we go for the TDAP in this pregnancy? What is your idea?
So because it has also includes the third component of the acellular pertussis vaccine.
What is the need of the pertussis vaccine? How the pertussis is useful in this pregnancy? On the contrary, one more component, right, which usually we don't want anything extra in the pregnancy. So what is the role of this pertussis component during pregnancy? That means what? To whom you protect from the pertussis? To the mother or to the fetus?
Antibody form will goes to the placenta through the child
Yeah.
also.
Then what is need birth? You know that the newborns are usually getting these passive antibodies for most of the infections. And therefore, they are not vulnerable to develop the disease. And therefore, our vaccine schedule also, if you know, we have started later on, not at the time of birth. But then what is why the pertussis want to protect the baby earlier? You know, in the examiner is not only interested in the case which you have prepared. He wants to assess as a whole whether you are aware of all these components of pediatrics or not. You know, pertussis, there are two infections for where baby is not getting the protection from the mother. And in the newborn period, if these infections develop, they are more serious and even complicated and at times even fatal. One is the pertussis, second is the varicella. Because pertussis baby is not getting protection, we want to give this TDAP to the mother so that antibodies will be produced, as Kailash said, and baby will get the protection. So that's the idea, and therefore we go for TDAP. Similarly for D. But why then the small d they have mentioned and small p? E is capital, but D is small, P is also small. Why?
During pregnancy, sir, acellular pertussis is better if than live vaccine.
For acellular, I will keep the A, but why the P small?
Because sir, after 5 years, sir, we are giving acellular pertussis vaccine, sir, not whole pertussis vaccine, because the chances of infection of acquiring pertussis is less after.
But Gunjali, what I said that why even the small p? For acellular, I will keep the A. Agreed. The point I think you should know that after the 5 years, what Gunjali said, lesser the concentration of the antigens to decrease the reactogenicity. And therefore, pertussis small p, that means concentration of the antigen is less. Diphtheria also it is less. And therefore, we mention small t and small p. Anyway, but I think this is important, which somebody may ask. Dr. Somsagar, you can take it further. Sorry, please.
Yeah, so sorry. So I had a few more questions based on the history. Yeah. So one, I looked at the weight gain. You said mother gained weight of 8 kg and she was 42 weeks before pregnancy. So question one, is that weight gain adequate?
Sir, approximately around 11 to 14 kgs weight should be gained in the entire pregnancy. But sir, the mother was undernourished. Sir, the mother's weight was 42 kg pre-pregnancy weight, and even she had delivered earlier. So the only 8 kg weight gain was there.
So is it
so it is not appropriate, sir.
So it's like probably just around okay, but because she had another 2 months to go,
yes,
and she might have gained another 2 or 3 kgs, so that's fine. She also received blood transfusion.
Yes, sir.
Which signifies that she was anemic.
Yes, sir.
That was quite interesting. So I don't mean it's not a good indication that if she has anemia, then the baby would have a lot of effects. Now Before we go ahead, I want to ask if Dr. Naveen Jain has any questions to ask.
I'm sure that Dr. Naveen is there. Dr. Naveen, you can take further, which I will say further issues. Please. Nice to see you.
Sir, thank you so much. And it is a very good discussion. I can hear clinical science is being discussed in so much detail. Just one answer to what you had asked the students about clinical approach to respiratory distress. Two important points they need to see is, are there retractions, grunting like you had pointed out, and second is how much oxygen is required. So if a baby has oxygen need and retractions and grunt, it is mostly a lung parenchymal problem. Whereas a baby who has not much oxygen need, it may be a transient problem like TTNV and airway problem. And the diagnostic causes like pneumonia, TTNV or RDS often come from history that has been discussed. So clinical examination at the bedside, if there are retractions and grunt, they need to consider giving pressure like CPAP, maybe even surfactant after that. And if the baby needs oxygen, it indicates that there is a severe lung pathology. That is all I have to add.
Yeah, I think very good point for differentiation. At least from the exam point of view, I would point out to students. Commonly they will ask, you said iron folic acid tablet was given to the mother. What is the dose of these two components which is given during the pregnancy to the mother, supplementation? And what is the duration also, which is recommended by Government of India?
So the IV tablet.
First, what is the concentration of iron and folic acid in one tablet? Jari, any idea?
Yes, sir. So 60 mg elemental iron. So the RDA. And sir, it should be started at starting of the second trimester.
Folic acid?
Sir, folic acid, sir, the dosage is around 0.4 milligrams, sir.
Is it?
4 mg.
0.4.
Is it this concentration in the tablet which is we are supplying to the mother during the pregnancy?
सर सर पूछ रहे कि टैबलेट कितने मिलीग्राम की होती है? 0.4 होती है कि कुछ अलग होती है?
सर टैबलेट 5 mg की होती है.
5 mg.
5 mg tablet available in government setting.
Folic acid.
Yes.
Is it? Just I will say that please check it. At the same time, somebody asked that you know that we are giving the supplementation to the children also. Iron folic acid.
Yes.
What is the concentration of iron folic acid in the supplementation for the children? You know, in the pediatric OPD, it must be there.
Sir, in the syrup IFA, sir.
I'm not talking of syrup. Jali, their syrup is not available in the government supply. The government supply, the tablet is, what is the color of the tablet, you know, for the supplementation to the pregnant lady and supplementation to the children, iron and folic acid. What is the color? Color is also spelled from the distance you can say.
Sir, brown color. Red.
Okay, brown color is for?
Sir, mother.
Yes, for mother, right. Brown or red sometimes you say. Okay.
Yes.
And what is this color of the tablet for the children? You know why I'm asking
Yellow.
this question, Kailash? Because examiner will come to know whether you have worked in the pediatric ward and in this immunization clinic or somewhere where you are giving this. And you know, government of India wants basic pediatricians. Because you know this country needs the basic pediatricians. I think it's a green color, not the yellow. And supplementation in the children is 20 milligram elemental iron and 0.5 milligram of folic acid. For the mother, yes, 60 milligram elemental iron, but folic acid is 1 milligram. And that is sufficient. So I think it is, you know that these are the very important programs of Government of India, which is, I will say, required for even these remote places, and basic pediatricians should know all these aspects. Anyway, another thing, what other investigations you would like to do during the pregnancy to the mother?
Sir, we would check the RBS monitoring during the then BP monitoring should be done, sir.
Right.
Then, sir, regular monitoring of the blood reports like CBC and all, sir, for the
Gunjali, specifically, being pediatrician, we are interested to know which can affect the baby. RBS just because diabetes, we have to just test diabetes, we have to detect hypertension, toxemia, yes, but what are the infections which routinely screen in your, I will say, antenatal OPD?
Sir, your voice is breaking, sir. I'm not able to understand.
Am I audible?
Sir, can you please repeat the question?
Yeah. What particularly that the congenital infections are common in these babies if the mother is suffering from that? So which are the common infections you go for the screening in the antenatal OPD?
Sir, we can do, sir, torch infections regarding the torch infection report.
No, I think you have not got my question. Routinely, we go for the every antenatal lady. When
Yes.
you are suspecting, it's a different situation.
Okay, sir.
If you have seen the antenatal card, in mother's card, they must have written that they have done this test and they are negative.
So
which
that
test they do?
HIV, HbSG, and HCV.
Yeah,
sir,
HIV they do.
Yes, sir.
Then which other test?
Hepatitis C virus.
Hepatitis C they
HbSG
do.
virus. HbSG virus.
One more.
Syphilis.
Yeah,
HbSG,
VDRL
sir.
they do. VDRL they do. And this is very important. Okay, suppose some obstetrician is your friend in asking that this pregnant lady, anemic, seems to be iron deficiency, started iron, but not responding well. What he should do?
First, check the compliance.
Yes, that he has done. That's good point. They are done. Mother is taking good compliance. When they have weight is sufficient, but there is no rise of hemoglobin.
Yes, sir. Pregnancy going there is dilution, so maybe that HB increases.
No, Kailas, I'm asking purposefully that if something is there that can affect the baby also in the future. Every question, I think most of the examiners will ask you with some idea, not just randomly. That means there is some reason. Which condition is likely in the mother which is not allowing the rise of the hemoglobin in spite of the iron supplementation, and I will say therapeutic dose. Then mother is suffering from some disease, and suppose father is also having in the future. Yeah, so always keep in mind, right? And this is very common that how the thalassemia particularly trait is picked up during this pregnancy.
Yes.
How many minimal antenatal visits is recommended?
4.
4 antennas.
Okay, very good. And how many USG scan is to be done?
At least 1.
Okay, and at what time?
During second for 14 weeks around.
14.
I think from this point of view, let us to learn from Dr. Naveen. Dr. Naveen, can you take this point that during the antenatal period, minimum visits and even the scan particularly, and particularly the anomaly scan when it is to be done, can you take this point for us, please?
So, although there are a number of antenatal visits recommended by Government of India, and most of them say at least 3 scans, but we have to look at that when it came to number of visits and outcomes, it was found that only when there are high risk pregnancies, increasing the number of visits really improved the outcomes. But basic screening for high risk would require these 2-3 visits where many of the basic points which sir is enumerating are. An anomaly scan should be done by at least 18 to 20 weeks, because if there are anomalies which need to be addressed in terms of termination of pregnancy, then till recently the MTP Act was allowing termination only till 20 weeks of age. Yeah. There are modifications in this MTP Act, which I think the students must also look at.
So I think very good point sir has taken. The anomaly scan around 18 weeks, and with this modification, I think with this medical termination of pregnancy, that we should keep in mind. Anyway, I think what Gunjali has not mentioned, probably, I'm not sure whether I missed, what is the blood group of the mother?
Sir, mother was A positive.
Acha, you have mentioned?
No, sir.
Okay. Probably somehow I didn't note it. But that also we should keep in mind.
Yes.
Anyway.
I don't think she said it. I don't remember her.
No, sir, I have not mentioned.
No, she has not mentioned. She said she's not mentioned. You know, in the examiner, if I remind you, there are 6 examiners. And so everybody will note something. And only one candidate has to answer every question. So I think you should be very, very vigilant. Anyway, any further question, Dr. Somsekhar?
I think we can, because we already...
In the history point of view?
Yeah, so I think we are already at almost 1 hour of the discussion.
Dr. Gunjali, did you mention any polyhydramnios or oligohydramnios history?
No, sir, no. History of leaking PV was since 10 hours, sir. But there was no USG.
Dr. Kailas, why I'm asking the question of polyhydramnios or oligohydramnios? Suppose if it is there, different mothers, oligo or poly, how it makes difference in my thought process, or how it helps me?
If polyhydramnion, then we, after delivery, we suspect the esophageal atresia or duodenal atresia. And oligohydramnion, then we think of renal anomaly or urinary tract anomaly.
Whether it can present with the respiratory distress?
Yes, sir. Diaphragmatic hernia.
Okay. What lung problem can develop?
Sir, in
when there is
oligohydramnios, pulmonary hypoplasia.
Yeah, pulmonary hypoplasia. And always keep in mind, suppose baby is at oligohydramnios and develops this respiratory distress, that we can keep in mind. Of course, maturity and other factors will be playing there. I think Dr. Somsekhar, you were saying something, please.
Yeah, so in the history again, on whatever she has presented, she said baby is 1.5 kg, 1500 grams at 32 weeks. So it is an appropriate gestational age or small for gestation. It's a good, it's a fairly appropriate for gestation. So despite the mother having low weight and despite the mother having anemia, why is it that the baby is not low weight?
Sir, the baby depends totally for everything on the mother. So even if the mother is undernourished, sir, the baby gets all type of nutrition, and so the baby's weight is not affected, sir.
Right. Maybe sometimes they are low, but usually they can manage. Another question is, this baby was started on formula milk, which was a little bit surprising to me. Baby was not breastfed directly after birth, 1.5 kg.
Sir, we had put the baby on a CPAP machine, sir. So, and the baby also had distress, sir. So, sir, we had started trials to feeding.
Okay, and there was no express milk that was given?
Yeah.
No, sir. Just after delivery, sir, it was not possible to give the express breast milk, sir.
So, in general, on day 1 or day 2 of life, what is the amount of milk that is expected that a mother will secrete? What is the range?
Sir, in the just after delivery, sir, in the first day, sir, around 25 colostrum is secreted, sir. So gradually, then gradually the amount secretion it increases, and maximum secretion.
Agnes, please put mute because, yeah, go ahead. Yeah.
Yes, sir. And maximum secretion, sir, it is there at around 5 to 6 months of delivery, after delivery, sir. Around 600 ml.
So you don't have a milk bank?
No, sir, we don't have a milk bank.
I think we can stop and we can go forward.
Okay.
We have only 1 hour remaining.
You can go for examination, you can start sharing your PPT.
So general examination. I have examined the baby in proper light and exposure in the stage for consciousness according to the practical scale.
Agnes, please keep your thing on mute. Yeah, go ahead now. Yeah.
According to the practical scale after taking consent from the mother. Sir, I had examined the baby on 15th day of life only, sir. So the baby was lying with both arms and legs partially flexed. Head to toe examination. No gross external deformity was seen. Anterior fontanelle was open and measures 2 by 2 centimeter. Posterior fontanelle allows the tip of the finger. The sutures are separated. No pallor, no icterus, no cyanosis or no edema and no sclerema is seen. The external genitalia is normal. Skin is normal. Back and spine normal and umbilicus normal. So the new Ballard score was 30 to 32 Richter. So anthropometry. The weight is 1500 grams. Height is 41 centimeter and head circumference is 28.5 centimeter. I have plotted this on the Fenton's preterm growth chart, sir. So, sir, we can see that even the baby is appropriate for gestational age and the head circumference and length is, sir, they are in the range. Vitals of the baby. The temperature is 36.6 degrees Celsius, exhaled temperature with the periphery is warm. The pulse rate is 134 per minute with central and peripheral pulses palpable. The respiratory rate is 44 per minute, a regular rate. The capillary refill time was less than 3 seconds and the saturation was 99% room air. Systemic examination. Respiratory system. The baby was spontaneously breathing on room air with the respiratory rate of 44 per minute. There were no chest retractions and with clear sound and the bilateral air entry was present and equals. CNS examination. The baby is active and alert. The cranial nerve examination is normal. The tone is normal in all 4 limbs and the power is more than 3 by 5 in all 4 limbs. So reflexes, the DTR is normal and plantar is equivalent. Coming to the reflexes, rooting, sucking and swallowing reflex is present. So the Moro's reflex is incomplete. The palmar grasp and the plantar grasp is present and the asymmetric tonic neck reflex is absent. CVS examination. S1, S2 is present and no murmur is found. Per abdomen examination is soft and there is no abdominal distension and no organomegaly is seen. So provisional diagnosis. Preterm 32 week, normal vaginal delivered. Birth weight was 1.5 kg, low birth weight, appropriate for gestational age. Respiratory distress syndrome and neonatal jaundice due to the prematurity. Sir, I have put the pre-surfactant and post-surfactant X-ray here, sir.
Can you stop sharing? I think only examination, then we'll go for the investigations, whichever you have performed. I think first the students, any question, any query to Dr. Gunjali, which you want some more information or something she has missed on examination? That means she has done the very good job. Or sometimes, the friends will protect her. That we'll talk later on, but not on the screen. Because next time I'm going to be presenter, that will be the thought process. But the friend should be such in the academic discussion that very first, as soon as she completes, you should say this is not fair. This is something she had missed. Or I don't agree. I think always the discussion should start like that. So that there should be healthy competition and good discussion. Try to find out some issues with Dr. Gunjali. Anybody? What she has missed to examine? The newborn specifically, which we expect and routinely we should do. Particularly if I give the hint, very specific, some pulsations. In the newborn, it is important. Which specific pulsations? It is said that for the newborn, always perform the habit that you should go for the examination. And second, people say that always don't miss to brace the baby. To brace that means examination of anterior frontal head. And you should always go to the feet of the baby. That means examine the dorsalis pedis of the femorals. Right? Why they have made even this? Dr. Gunjali, did you mention the femoral pulsations?
So central and peripheral pulses are given, sir.
Yo, it's a generalized statement. It's not right. Right. I think in the court of law you may get it, but I think the clinical examination it is incomplete. Which peripheral pulsations you examine, right? That is very important. Here, very specific pulsations are important. But suppose if I get the baby breathless, and later on I got that as femoral pulsations are also affected, then what is the likely problem? And child is breathless even. May not be immediate at the time of birth, later on. But newborn.
So coarctation of aorta, sir. In that case, femoral pulses are not palpable.
Then what happens? Why the child is breathless? Why the child is breathless?
Sir, because then it will cause left volume overload, sir. So that's why that can lead to.
So child can be in cardiac failure.
In cardiac.
Right, and therefore the respiratory distress. Now, can you give me some conditions, cardiac conditions, where the respiratory distress is there in the newborn period? Newborn period. One is, as you say, coarctation of aorta. Any other condition? We maybe with cyanosis, without cyanosis, you can classify in that way.
Sir, patent ductus arteriosus.
Any other person can take. Kailas, you can take. Because it is possible that Gunjali might have come with some preparations. All of us are without preparations. On the contrary, next time I will give the idea. Don't even give the title that respiratory case. Newborn with breathlessness. We don't know. It can be metabolic disorder also. Right? So even don't give any clue. No any system. Yes, Kailas?
Sir, left ventricular outflow tract obstruction.
Like?
TAP, we see total anomalous pulmonary venous congestion.
That will be with cyanosis or without cyanosis?
With cyanosis.
In other ways, suppose if I ask the question, I'm sure some examiner is going to ask in the Viva also, or in some newborn case. Which is the most common cardiac malformation in the newborn? Or what are these common? And which is the most common cardiac malformation presenting in the newborn period?
So structural or functional?
Yes, Kunjali, what did you say?
Sir, structural malformation or functional also, like PDA?
You can take both the way. You can take both the way. What is structural?
Yes.
In other way, if I ask, yes. Kunjali, I want the answers from you, from students.
VSD, sir.
VSD common presentation at what age VSD presents? Common age of the presentation of VSD.
It presents after 2 to 3 months, sir.
Yeah.
Not in the newborn period.
Usually after 6 weeks, 6 to 8 weeks. Why they present late? Malformation is there already.
PDA, sir, functioning PDA.
So we'll explain. This can you take?
Sir, intact PDA, sir, can help in up to 6 weeks.
How the PDA will help? On the contrary, PDA will add more problem. One shunt is there, suppose one more shunt. I hope that you got my question. That VSD, lesion is since birth. Commonly they don't present or don't manifest in the newborn period. Usual presentation of the VSD is 6 to 8 weeks or even beyond that. But not the before usually 6 to 8 weeks. Why? Anybody? I think this is very common question. I'm sure if you know the VSD is very common congenital heart disease in pediatric practice. And I think hemodynamic circulation, you must be aware of it. Then you can answer. Why they don't manifest earlier?
So the anatomic closure of ductus arteriosus, sir, it takes a few weeks, sir.
But how it will make difference in the presentation, manifestation of the VSD? Kailas, unmute yourself.
Pressure between the two ventricles are during the neonatal period same. As the difference arises, then it will be clinically manifest.
Can you explain what happens, what difference is, and then how the difference
Pulmonary
takes place?
resistance.
Agnes, what I will say, suppose undergraduate student answers me this way, I'll be happy and I will give the marks, but not to the postgraduate. Postgraduate should have the very clarity, proper explanation, not just patchy words, right? Because you should be able to explain that why it happens so. Suppose Kailash said some pressure changes, you said pulmonary pressure, but I think it does not explain me the exact reason for that. So as a postgraduate, I want to sensitize you that in the exam, go with the preparation. You know, Ambedkar sir says ABC, accurate, brief, and clear. I think I have got this, sir, that your answer should be like this. It should be very accurate, whatever they have asked. It should be brief, and clarity should be there. Coming back to this question, you know that the pulmonary pressure is more at the time of birth. Therefore, right-sided pressure is more. And therefore, pressure gradient difference in the left and right ventricle, which is expected, is not there. Therefore, in spite of the gap, there is no flow. Left to right shunt is not there. If there is no shunt, no manifestations. As this pulmonary pressure, pulmonary arterial, you know that the changes are taking place. That also you know the physiology, that they are in the coiling, they become straight, pressure goes down. So many factors are playing the role, but in short, right-sided pressure goes down. And then what happens? The right-sided pressure goes down, left ventricle pressure is more. And therefore pressure gradient is there, difference is there. And therefore flow is established from left to right. And with that establishment of flow, there is the pulmonary congestion and reflect in the form of the cardiac failure, and therefore the manifest in the form of the cough, breathlessness, signs of failure will develop. So that's the mechanism. But you know that that will not be unless very large VSD or single ventricle, they don't manifest in the neonatal period. My question was, what are the most common cardiac malformations which are present in the newborn? Suppose mother is diabetic mother and there is some cardiac malformation, which is most common. That means infant of diabetic mother.
ASD, VSD are common, but their
No, Kailas, my question is very specific, and what I said answer should be accurate. And therefore, answer question is infant of diabetic mother is such a baby which is the most common cardiac malformation.
Cardiomyopathies.
Which is less common and which is transient. Here it's not transient. It's a big issue. It's related to the vessels. And it is commonly the cyanotic.
So TGA, transposition of great.
Yeah, transposition of great arteries or vessels is the most common in the infant of diabetic mother. And even cyanotic heart disease in the newborn is most common TGV. What is the another cardiac malformation? Cyanotic presents in the newborn.
Sir, left hypoplastic heart syndrome.
Okay, what do you call it? You know, that can be diagnosed only by ECG, even without echo. Because patient is having cyanosis. Patient maybe even, and when I examine, or suppose if you go for ECG, ECG changes are showing right ventricular dominancy. Sorry, left ventricular dominancy, which is not expected in the newborn. And what is it?
Sir, tricuspid atresia.
Yeah, tricuspid atresia. So always keep in mind in this way, right? But you know, the in cardiac malformations in the newborn period, very easily missed because our focus is respiratory. And I'm sure you will agree with me that the newborn, any disease, manifestations are common. Even symptoms are common. It become the lethargic or irritable, not taking feeds, activity decrease. That can happen with even simple sleeping to mild hypoglycemia to serious condition. So we'll have to keep the whole spectrum in the mind. Right. Anyway, suppose child developed this problem, child was healthy and hearty, even full-term baby, weight was good. No any period, any problem in the first 7 days, taking even breastfeeding well. And now child presented to you with the breathlessness, respiratory distress. There is no respiratory cause, no cardiac cause, common causes I excluded. I am not able to explain. What you will keep in mind?
So we have to see for severe dehydration also, sir. In that case also, the baby's weight, the baby can develop breathlessness and...
Very good. But what is the cause of dehydration? There is no loss. This baby, there is no loss. Okay, to some extent dehydration is there, but there is no loss. Even the breathlessness is disproportionate to the dehydration.
RBS we would like.
RBS was also affected, suppose low. And even ABG suppose is showing acidosis. Then what it could be? Initially child was normal. After 7 days, 5 to 7 days, taking breastfeeding well and suddenly gradually develop this problem of respiratory distress for the child. Acidosis. Yeah. And then what it could be the reason?
Inborn error of metabolism, sir.
Yeah, I want to sensitize you. That initially, naturally, everybody will keep on respiratory cause. Suppose I don't get CVS, I don't get. Now I'm not able to explain. But suppose if you, and you know, classically, why it develops after 5 to 7 days? Why not initially?
The feeding was started and then
after starting feeding, maybe galactosemia.
Not necessarily galactosemia will not present in this way. Galactosemia different presentation. You know, sometimes students are giving the question to the examiner that now ask the galactosemia. But you know, galactosemia presents in a different way. That will be persistent jaundice organomegaly, cataract, and that cataract was not at the time of birth, then you may think keratosemia. But I think that's a condition with organic acidemia or even urea cycles. So after giving the feedings, it will start. So actually what even Dr. Somsekar was concentrating on some of the points, very important. That history is very important. Onset, that on which day the baby became the breadless. That is very important. That immediately, suppose transient take now newborn also, you know, that usually all these breadlessness develops after the few hours. But another child brought with the breadlessness. I put my statho, that left side air entry diminish. Heart is on the right side. What it could be?
Sir, diaphragmatic hernia.
Congenital diaphragmatic hernia.
Absolutely. And therefore, in the newborn, always what I'm telling to my student, you know, the small chest, very difficult to auscultate the wind, which you are doing in older children. Just always my focus will be on the air entry. I don't expect any foreign sounds in the newborn. Right. So air entry is very important. And air entry diminished can be any other reason. Suppose any other reason, what is the congenital hernia? Yes, that means very important. Pneumothorax can be there. Not common, but sometimes pleural effusion. Right. So air entry is very important for me. And then I will look at the heart sounds. They're anyway affected. And at the same time, what I will look for, suppose it came to my mind, diaphragmatic hernia, then where I will look for so that it will help me. That means what is the another finding?
So scaphoid abdomen.
Scaphoid abdomen. Very good.
Scaphoid abdomen.
You know why I'm coming to this point? All of us know, but when you see the baby, this should come to your mind. That breadless baby, left side air entry diminish, heart sounds right side, abdomen is scaphoid. And why we are discussing, you know, it's a treatable, manageable surgical condition. Right. So this is very, very important. On examination, in short, you should look for. I think Dr. Somsekar, you can take it further. I'm sure you must have the several points. Being the neonatologist, I am just general pediatrician.
Nah, sir. You are a very learned teacher, and we are learning every time from you. So I coming back to what I wanted to ask in history, and I did not ask earlier. We talked about steroids, and this baby was like 32 weeks, and baby received steroids before baby was like for preterm delivery. So any other drug that is used for babies who are likely to be delivering before 32 weeks, apart from steroids? I don't know if my internet is good or not. Can you hear me?
Yes, yes.
Okay.
You're audible very clearly.
So I am not hearing any answers from the students, so I was wondering.
If preterm delivery is expected, then MGSO4 to the mother.
Very good. Why? Very good. Why? So magnesium sulfate is kind of becoming another drug which is going to be very useful. While it has been usage for many years for mothers for preeclampsia, which of course again we know we get a lot of preterm babies because mother had preeclampsia. What has been seen in babies who are likely to deliver before 32 weeks, giving magnesium sulfate reduces the chances of cerebral palsy significantly. So there are quite a few recommendations which suggest that we should be using magnesium sulfate for babies who are likely to undergo a premature delivery before 32 weeks. So that's one more indication where magnesium sulfate is becoming more like a more prominent, cost-effective, and easy drug to use. I think 20-30 years back, obstetricians were kind of afraid or there was a difficulty in using magnesium sulfate because of maybe what they thought was the small therapeutic window or side effects of magnesium sulfate. But a lot of people use it quite commonly nowadays, and it's quite easily useful. So it has been seen to prevent cerebral palsy at around 2 years of age. So It is recommended by various societies across the world, as well as WHO, for babies who are likely to be born before 32 weeks. So that's some significant. So magnesium sulfate, antenatal corticosteroids, tetanus toxoid, all of these things have had a tremendous impact on respiratory distress syndrome. We have about half an hour left, and I thought we can. Can you hear me?
Yes.
Okay. So I thought we should little bit focus on
Yeah.
the distress syndrome that we generally think, and which is the most commonest one, which is which was called
Yeah,
Halley disease
I think
earlier.
definitely we learned from both of you that can
So-
for this. Dr. Naveen, would you like to say anything before we
Yeah,
go further?
yeah, I think
Anything from Dr. Naveen?
And so the discussion is going on very valuable.
Sir,
And
we must have discussed the, I would say, superficial point for general pediatrician. Now you can add more, please.
Dr.
Thank you,
Naveen,
sir.
please go ahead. Naveen, please go
Yeah.
ahead.
So we have reached a critical point which Somshekhar clearly identified, that respiratory distress syndrome is something pediatric residents, pediatricians, and neonatologists would keep seeing. And early care, beyond just looking at distress, would be important in the labor room. So I would like Dr. Punjali to address how she would stabilize the preterm baby in the labor room. Besides just giving respiratory support, what are the other important things we do in those 20 minutes or 15 minutes, although we call it the golden minute, first 15-20 minutes while you're handling this baby, other than respiratory support?
Sir, first of all, we have to maintain the temperature of the baby. The newborn babies, they have high risk for going in hypothermia. So it is important to provide the temperature support. After that, even after the birth also, then when we provide warmth to the baby, then and after that, sir, even the circulation of the babies, like after the feeding has also to be started. After the when the baby's distress is settled. After that.
Any of the students would like to elaborate on how they would help this preterm baby to remain warm when it comes in comparison with other term babies?
We can directly put the child on the mother's chest. Even active resuscitation with the attached umbilical cord is now being researched upon. So,
yeah, so Agnes, that was a good point you made, but I think that's more for currently a subject for research in term babies. I don't think we are yet ready for using it in every place, even for term babies. So I would want to avoid that discussion for preterm babies currently. While the current recommendations do not, for this particular baby, do not recommend keeping this baby on the mother's abdomen. Many other European countries keep such babies directly on mother's abdomen and then decide to continue the baby on that place on mother's abdomen, or do cord clamping at 30 seconds or 60 seconds and then shift to the warmer. But I think in our setting currently we are advising delayed cord clamping for sure, and then shifting to the warmer for maintenance of temperature. So I please continue answering. I thought I just talk about these two things. So I don't think we should be discussing intact cord resuscitation right now. It's a very interesting topic, and I believe it will become the future by at least 2025 or 2030. But we are not ready for it currently. In fact, I think Chennai, Dr. Mangalavarthi and team have developed an indigenous bed, or what do you say, a warmer for intact cord resuscitation, which has been published, I think, last year. But it's still not the norm as yet. Please go ahead and continue answering what Dr. Naveen Jain asked.
Yes, Dr. Kailas, you were responding.
So to prevent heat loss or temperature maintenance in your preterm baby, we should receive the baby in pre-warm linen or in heat mattresses or in plastic bag, and directly put in a already warmed warmer to get maintain the temperature.
Okay. Dr. Naveen, anything from your side, or I think whatever the investigation they have, should we look for?
I think they have set good points about keeping the baby warm. And how would you prevent infections in these babies? Because this is something again which will determine the outcome of these babies.
So just before you go ahead, I think the recommendation of the American Academy of Pediatrics and even IAP and NNF in their NRP training programs very clearly mentioned that babies less than 32 weeks, so this baby would have been around that gestation, should be placed in a plastic bag and kept under the radiant warmer without drying to maintain temperature. So that is for less than 32 weeks. There are some studies which say that even above 32 weeks this can be done, but the current recommendation is for less than 32 weeks. So for maintenance of temperature, that becomes very, very important. Dr. Naveen, you want to add something, anything else?
No, I think it's just fine. They can also add points on prevention of infection. Then the baby is shifted to the NICU. What X-ray findings may suggest that baby has RDS?
Dr.
the X-ray.
Dr. Naveen, I think she had these plates. Should we allow her to share so that we can see?
Sure, sir.
Yeah. Dr. Gunjal, you can share your PPT, whatever the investigations and X-rays you have.
So, sir, the left one is the pre-surfactant X-ray. It was taken before giving surfactant, and sir, the X-ray findings
I
in
think
the RDS, sir.
I think Dr. Gunjali, let sir take. Dr. Naveen, sir, can you take this both the X-rays and can you explain the points to us?
Yeah, what they should be looking for in the X-ray is that an air bronchogram is a very, very important finding because it goes beyond all the quality issues. It is trying to show that there is air inside the bronchus, whereas there is no air outside the bronchus. So if you can see an air bronchogram in a reasonable quality X-ray, then you can kind of be sure that there is atelectasis. Other points are also important, which often we discuss, that how many lung spaces are there, but these will be determined by also whether it's inspiratory or expiratory film, and things like reticulogranular pattern, which is a very subjective thing. They must look at the grayness inside the lung and also inside the area on the stomach where there may be some air. Somshikar, you would like to add?
So actually, not for this particular thing, but in general, as we move and as we progress, as technology progresses, more and more people are relying on using lung ultrasound. I know it is not commonly available. Even we don't use it currently, but and we probably should be using it more often. A lot of people tend to use lung ultrasound instead of doing X-rays for determining whether we should be giving surfactant or not. It's useful, and that kind of helps. So that's one thing I just wanted to bring out. In as far as the X-ray is concerned, because many times it is difficult to get the X-ray on time. So if babies are born, if the setting is appropriate and you think it is respiratory distress syndrome, and which is clinically quite again as common, and so most common thing what needs to be done is the baby goes on CPAP. You have put the baby on CPAP as you have said earlier, and then you have given surfactant, which is I don't remember exactly how many hours after CPAP you give surfactant, but that's the commonest what do you say timeline that is done. So baby is delivered, premature baby has distress. Your provisional diagnosis is respiratory distress syndrome. which signifies that, which indicates that there's a lack of surfactant because of prematurity. Then you start CPAP at maybe 6 or 7 centimeters of water, depending upon the unit protocol, and with FiO2 of maybe 0.3 or 0.4. And if you feel that the baby is not improving on CPAP, then you could start. Then you would give surfactant, which is what you have done here. So what has happened in the last maybe 10-15 years is using antenatal corticosteroids, using early CPAP, and maybe early surfactant. The chances of babies going on to long-term ventilation or having prolonged neonatal stays because of respiratory issues has reduced significantly. So these are actually quite significant indicators. And Dr. Naveen would agree. The number of babies getting invasively ventilated, mechanically ventilated with the tube in situ, has gone down significantly, and most neonatal units, many of the ventilators which were bought maybe 10-15 years ago, are not being used, and what are being used commonly are either CPAP machines or high flow nasal devices and NIPPV. Or so there has been a significant change in neonatal practice over the last 15-20 years or so. I think I'll stop here. Dr. Naveen, anything else you want to add, or anything I missed? Or
no, actually, you're right. And so they need to look at factors on the X-ray, but most importantly, they must also look at what kind of support the baby is on before they report the spaces in the X-ray. So if the baby is on CPAP or intubated, then he may be having a well-expanded lung, but that may be appropriate to the kind of pressures that he's getting. So when you comment on the X-rays, please also see whether you see an ET tube down there, whether you see or you know the information whether the baby is on CPAP or not. That would be it.
Okay. Dr. Gunjal, you have any other investigations?
No, sir, I've only taken the X-ray part, sir.
Okay, can you stop sharing that?
Yes.
I think we'll go further to learn from the experts. But before that, I think, Dr. Naveen was pointing out that the X-ray, you'll get the air bronchogram. Why it happens so? And what do you mean by the air bronchogram? Sir actually tried to just draw our attention. Any student can take. And on the contrary, in the newborn, very rightly, sir said about the preterm baby, if you take child is like the respiratory distress, if you take the X-ray, and with even suppose these the multiple reticulonodular or even some other opacities, if you get this air bronchogram, it is very classical. As Dr. Somsekar was talking of advanced sonography probably may come in the future, but at present we are learning from these plain X-rays. And he said that the air bronchogram is very characteristic. What is the air bronchogram? How it happens? Anybody can explain?
Sir, the bronchioles are remain open patent. It seems on X-ray black on the white background of that closed alveoli that remain seen as a white atelectic alveoli white. So the black and white pattern are seen as air bronchogram.
Even can you get this air bronchogram in older children also in some condition? The chest X-ray.
Yes, sir. During pneumonia, if consolidation severe occur, pull out the lungs.
Why the pneumonia? Just simply try to understand that normally in the alveoli there is the air.
Air.
So it will be appearing the X-ray black. But when they are opacified, if the collection of the fluid commonly exudates, suppose in a case of pneumonia, or in the newborn, you know that it is filled up with the fluid, and therefore alveoli are opaque. Therefore, sometimes you may get even total white lung, right? Or even some suppose there is the multiple atelectasis, then reticulonodular appearance will be there. But with that, that is alveoli are replaced by fluid rather than the air. Therefore, they are white or opaque. But the airways are containing the airway, and therefore they are looking at the streak like black, and that is the air bronchogram, which is very characteristic. I think very nicely served your attention, and even various conditions you should keep in mind in X-rays also in the viva. Suppose the baby is breathless. already somehow, fortunately, this is a term baby, and presented to me with a respiratory distress. X-ray is taken, and my resident sent to me with this diagnosis of some distress, maybe hyaline membrane. But in the X-ray, in the fissure, I got the one characteristic, which is the characteristic of another condition, mimicking to the hyaline membrane, but it's not hyaline membrane. What is it? The horizontal fissure is very prominent. And meanwhile, after a few hours, I talked my resident, how is the patient? And he said that the now distress has decreased.
Term baby, so TTN, it could be transient tachypnea.
Yeah. You know why I'm coming to these conditions common daily we are facing the problem. In the X-ray, what I wanted to their attention, with that even the suppose horizontal or the fissure as very prominent or containing even opacity, in a particularly more of the term babies, even it can happen in preterm also, but more in the term baby, particularly LSCS even where it is done in this situation. But here, you know, hyaline membrane disease, probably as the disease progresses, baby is developing more distress or deteriorating. While in a case of transient tachypnea of newborn, as I'm managing suppose with the oxygen or something, some supports, baby is improving. So I think that also will give the idea. And I think as a clinician, commonly, then of course, if I'm not competent enough to manage this newborn, I will take the help of Dr. Somsekhar, Dr. Naveen. But I think as a general pediatrician, you should be aware of it. And I think we can take these benefits of the advancement in the technology of the neonatology. But before that, I think you should be able to find out these situations and you can manage it properly, right? I think now let us focus whatever the few minutes we have from Dr. Somsekhar and Dr. Naveen to learn, particularly I will say hyaline membrane disease. Sir, I think it is very common for the MD pediatric students and UNB students to get even the full question in the theory or even in this some table the discussion. So can you take, I will say, hyaline membrane, how much it is common in our setup, common some presentations, and probably the management part can be taken by Dr. Naveen. Dr. Somsekhar, I think you can start it with this initiative.
Yeah, so I think what I would see, it's quite, I don't really know the real exact percentages, but a lot of patients, and it keeps varying. So I let me lay it out this way. Most of the preterm babies who are born and with respiratory distress and the setting of RDS are more likely to be RDS because of surfactant, and less likely, so unless you have a good history or an X-ray suggesting a congenital pneumonia, and if you see the X-ray as it was shown, it is more likely to be RDS. Now, what happens is if you're suspecting RDS, the first thing that you should be starting, preferably in the delivery room or as soon as possible when the baby is transferred to the NICU within 10-15 minutes, you should be starting CPAP, non-invasive ventilation. So there are various modes. So one, you can use bubble CPAP, which is the most common one, which is utilized. Some people use ventilator CPAP. There are a few people who have tried, but still not used commonly as the first mode of ventilation, which is NIPPV. But so CPAP is the most commonest one, which is used for managing babies with respiratory distress, because it splints the airways, ensures that whatever surfactant is available spreads through the alveoli and prevents collapse of the airways. Many babies, usually after starting CPAP, kind of improve, and they may not require surfactant. The whole idea of starting non-invasive CPAP is to avoid avoid intubating the baby. And if you do intubate the baby, then you need to kind of give surfactant immediately if such baby is required to be intubation as part of stabilization. This is all laid out in the European guidelines for respiratory distress syndrome and how to manage it. Now, one of the other issues is, if you looked at literature sometime before 2010 or 2012, what was indicated is, what was the literature showed is, if you give prophylactic surfactant, then there were better outcomes than giving what is called as rescue surfactant. Then rescue is divided into early rescue or late rescue. If you look at Cochrane review trials, then prophylactic surfactant had better outcomes than early rescue surfactant as compared to late rescue surfactant. But with increasing usage of steroids and corticosteroids, increasing usage of CPAP, what literature now shows, because the literature has changed, is using prophylactic steroids has no additional advantage, and in fact, some studies might show that it might be a disadvantage. So now the current way of managing such babies is what you have done. You started CPAP early. Now, coming to if you do you need to give surfactant in these patients or no? Now, it depends upon if the patient is not what we call is not doing well on CPAP or is failing CPAP or the FIOD requirements cross zero point 0.5 and the pressures cross commonly it's 0.7 or 0.6 depending on unit policy. But if the FIOD requirements go high and the pressure requirements go high, then a decision is made to give surfactant. Now, recently in the last 5, 6, 7 years, there have been newer modes of giving surfactant administration. Previously, 15 years back, 16 years back, what used to happen is we used to intubate the patient, and give surfactant, and then place the patient on the ventilator and slowly kind of extubate the patient after the patient improves. In 2008, 9, 10, there was a drive of increasing CPAP, and that around that point of time, a lot of people started using what is called as Insure, which I'm sure is what you might have done. Okay, so where you intubate and administer surfactant and rapidly extubate the baby. Around 90 to 90% of babies get extubated pretty early, in a few hours, and then they remain on CPAP. And they come off CPAP actually. So that 90% of babies. Now, my other question is, what are the other methods of surfactant administration that have been kind of used? What are called as Lisa, MISA, and so all of these are new methods, and few trials have shown that these have better outcomes as far as BPD is concerned. But there are others who currently insist that these trials were biased, and we may not always consider them as to be they can replace Insure. So a lot of people are using sure, a lot of people are using Lisa, and it is appropriate to use both currently, but it is not yet true to say that Lisa or these newer methods have replaced Insure technique. So the best thing is what we should always use is what the unit is comfortable with and what it is trained with, because giving surfactant via Lisa, etc., requires some kind of training across the unit, and it requires a certain kind of expertise. Now, interestingly, and this is not discussed often, and it is given me. So, what surfactant do you all use? Natural surfactant or artificial surfactant?
Yeah, I think Dr. Somsekhar, should I request Dr. Naveen to take this aspect?
Yeah, okay. Dr. Naveen, please go.
Dr. Naveen, you can take this, that what are the surfactants different available to us in the market? What are the, I will say, of our choice? And even the cost also is a major factor that I will say practically all of us should know. So can you focus on this aspect?
Yeah.
Dr. Naveen, please.
Yes, sir. We were lucky to see the evolution of surfactant brands in India. At the time when we were residents in PJ in 2000, we had a synthetic surfactant available to us. And after a year and a half of our training, we started seeing the use of natural surfactant. Although literature describes that natural surfactant is superior to synthetic, and within natural also we have this bovine and porcine. And there are literature suggesting small different benefits of porcine over bovine. But I guess natural surfactant has almost completely replaced the market, and artificial surfactant is rarely available. But the difference between porcine and bovine is very, very thin, and the cost and as well as the dosing issues being different. I guess more than choosing the surfactant, what the resident needs to know that it is cost effective. Even though we might listen at once and think that 13,000 for 8 ml or what is called as full dose, and something like 7,000 plus is expensive, but the outcomes of RDS is so good the use of surfactant reduces the need for invasive ventilation, and the babies have better outcomes. So just because we're closing to time, I think the only message I would like to give is, instead of choosing the surfactant dose or the brand, the residents need to understand that surfactant gives good outcomes in RDS and should be used when indicated.
Thank you, sir.
Yeah, so I just wanted to share. In India, some of the most common publications on CPAP have been done by Dr. Srinivas Murki from Hyderabad. And I think one of the things that he says about managing RDS, while the general literature in the West say that you start the patient on CPAP, and if the patient fails CPAP, then you give surfactant, and then mostly through insure technique, and then extubate the patient after maybe 1.5 hours. Most of them usually get extubated, and then maintain the baby on CPAP. So I remember him arguing that we should, that is a Western approach, and they have more resources. And because everyone may not get extubated, some of them might remain on mechanical ventilation. A more, what do you say, pragmatic approach for us would be is to put the patient on CPAP, and give surfactant. So don't wait for CPAP to fail. Give surfactant, and then once you have CPAP and surfactant both in the preterm baby, that baby is likely to maintain on CPAP and will probably not require mechanical ventilation. So I don't know if there's an RCT, but I think that's what he mentions, which I think is reasonable, because if you look at giving CPAP and giving surfactant and the patient not going on to mechanical ventilation, which means that the overall cost of therapy for that particular patient would actually be less, because if he goes on to mechanical ventilation, we don't know what is going to happen further. So that's one kind of approach that can be taken. I doubt if there's an RCT to suggest that that is a useful methodology in our setting, but it's pragmatic. Coming to natural and artificial surfactant, we recently published a paper in Indian Journal of Paediatrics where we compared natural usage of natural and synthetic surfactant. And as Dr. Naveen Jain mentioned, there is actually not much difference. There is a difference, but it's not much difference. So artificial surfactant has a higher rate of like pneumothorax and some side effects, but in terms of clinical usage or benefits, they are almost similar. And because when we did the study, artificial surfactant was available to us. The cost of artificial surfactant at the point of time was 5,000, 6,000, and natural was double, 12,000, 14,000. So what we did, why we used artificial surfactant is because if we tell a patient who's come, and ours is a private paying hospital, if you tell a patient you come on day one, you use surfactant, we will require to ventilate you or keep you on in the ICU. The cost of therapy on day one becomes 20,000. Next few days it will reduce, and the overall cost of therapy may not cost, in our setting, at least 60, 70, 80,000. Still, because the person sees that 1/4 of the cost of the total explanation is happening on day one, and day one they are so stressed, they will usually take the patient away. So one of the ways we thought was to reduce the cost is to just give artificial surfactant, and so your cost from maybe 20,000 comes down to 10,000 or 8,000 or 9,000. So that kind of ensures that the patient stays in the hospital rather than goes away Dama. So we thought that was a better way of looking, because ultimately we want the patient to survive, and by a patient going Dama or leaving the hospital not taking treatment, that patient is not going to survive. So that was our approach, and we found that it was almost equal effect, and there was hardly much difference between. So it's published in Indian Journal of Paediatrics recently, and if anybody wants to read it and wants the article, I can share it with them. So that's what I wanted to share.
I think Dr. Somsekar, last question. Now we are reaching to the end of this discussion. Commonly, I think we have the impression that surfactant, that means in the highly memory disease. But are there any other indications for the surfactant therapy in neonatology?
So meconium aspirant syndrome, people use it quite a bit. Like it's not commonly used, but people have tried, and it improves ventilation parameters. I doubt if it improves mortality differences or stuff like that. But patient ventilation parameters improve after giving lavage with surfactant. So I have not used it in our patients because the amount of surfactant that is required for lavage is high. The cost goes up high. So one of the advantages of having artificial surfactant, if it is available and cheaper, is people can try out that surfactant in other indications. Like the next common indication would be meconium syndrome. Another point is whether we can use 2 doses of surfactant. So if the patient gets a surfactant and patient improves and then again worsens, a lot of people use a second dose of surfactant. So that's fine. And sometimes people have used even third dose of surfactant. But using 2 doses of surfactant is not uncommon. But even that practice probably has reduced because generally now people are more comfortable. Maybe 15 years back, people used to not use so much surfactant. But now surfactant is available in government hospitals. It's easily available everywhere. It is still expensive. The cost has not changed much, but I think it's relatively cheaper because I think the cost of surfactant has remained more or less the same for the last 20 years, while incomes, etc., have risen. So technically speaking, it's not that expensive as maybe 20 years ago. And people are more, there's more experience of using surfactant, and hence outcomes are better. So people, and because you are more likely to use surfactant earlier today than later on, the chance of requiring a second dose of surfactant has reduced significantly. Previously, people used to wait for 1 day, 1.5 days. People used to do it quite late, not 1 day, like maybe 10 hours, 12 hours, and then decide and give surfactant later rather than earlier. And hence, these babies would require probably a second dose of surfactant. Now, usually most babies get within 2-3 hours, within 1 hour of delivery if they require it.
Dr. Naveen, last question. I hope Dr. Naveen is there.
Yeah, he's there.
Yeah. I think just you can enlighten some common complications of the surfactant therapy, which we should be aware of it. Dr. Naveen, unmute yourself.
Sorry. In fact, surfactant is quite a safe medication. And if used correctly, acute complications are very, very uncommon. And babies will not have problems while they're being surfactant. Sometimes they can develop a little bit distress, which may be due to the surfactant itself obstructing the airway. At that time, possibly we need to continue ventilation, sometimes increase the pressure a little bit, and that will just take the obstruction away. Long-term complications are also very uncommon, even though we would have thought it is an animal product and therefore they would develop allergies later on, or they would develop, some people thought that blood circulation will change suddenly and will cause cerebral issues. But it is one of the medications which has come to our portfolio, which is quite safe. And I would add to what Somshekhar ji was adding, that currently
I think his connection is lost.
I think he lost the connection. I hope he comes back. I have put a link of an article. Dr. Naveen, you were not here. You were not heard. After saying Somshekhar ji, we did not hear anything.
Dr. Naveen, yeah, last point. Yes. Now you are heard. Yes.
Yeah, we do use a little bit more of surfactant in both congenital pneumonia as well as in MAS, even in term babies. And the indication would be a clinical setting of a baby having severe respiratory distress, high FiO2 needs despite of optimal pressures or very high pressures and support. In such babies, surfactant insufficiency is a part of their illness, not the solution. So it might help in improving the respiratory outcome. So there are some studies which have shown mortality benefit, but they are only when the distress was very severe. So they may not go back to nitric oxide. You may save them from going to, in fact, even in PPHN, in a term baby, if you are having what is called a whiteout lung, an atelectatic lung, then surfactant has come on the top of the therapies. But I guess all the other important points that were discussed today as a clinical is very important, that before you reach decisions on surfactant in unusual situations, you need to assess your baby correctly. And just one additional point to the clinical presenters, you were very good, but try to put presenting complaint as a very, very important starting point. So when you put your presenting complaint clearly, like in pediatrics, then you and elaborate on the presenting complaint also before you go to antenatal, neonatal, and postnatal history. So when you talk about respiratory distress, you may give a short brief of how they started,
how much distress was there, when was support given, and when the baby came out. So that gives a lot of clinical perspective.
Thank you very much. I think we'll have to end over here because this we have reached to the 7 o'clock. Let me appreciate Dr. Kunjali. I will say it was really good presentation, and your selection of case, the way in which you prepared this PPT. Of course, always all of us know that there is scope for learning. So what I think Dr. Naveen mentioned can go for the modification, and I'm sure. But really, even you are confident, and even you're responding also very nicely. All other two students also, Dr. Kailas, Dr. Agnesh. I think I will encourage that next time come with your other friends also. I think maximum students should be there for the discussion. The way in which you know how it makes difference. The experts will speak, the teachers will teach, books, everything is given in the books. But when we learn with the interactions, which is I will say there is no any cost for that. Even I will suggest that otherwise also you exam going student make your group and go for this discussion. That is very important. I'm sure that it made difference in your exam presentation also. All of you were really very good with good, I will say, arguments, good response to the questions, and I'm sure that it will be quite useful in your exam. Please remember again, if I say ABC, which I learned from Dr. Ambedkar, that your answer should be accurate, it should be brief, it should be very clear. And I think if you perform this habit in the exam, the performance will be different. Thank you very much. And of course, I would like to appreciate Dr. Maulik as a mentor. I understand that you must have paid these more attention, more efforts for this preparation of the students. You know, for any student, you can understand that what is the increased work of this mentor. Then and then probably that production is available. We were fortunate to have both the experts, I would say renowned experts across the country and beyond country, Dr. Somsekhar and Dr. Naveen. I know Dr. Naveen since many years, and as Dr. Nehal mentioned, he is one of the editors in this developmental book by the Illingworth. And you know that Dr. M.K. Nair and Dr. Naveen has edited very nicely. I think from days of my residence, I remember that's the only book when you are reading as if the Illingworth is talking to you. He has written the book in such a style, and both our I would say Indian editors have maintained, not only I would say maintained, but even made very friendly to readers. You know, otherwise development and all these topics are such that people are losing the interest in reading. But they have made, I will say, very good presentation. And of course, we got even the good comments from both the experts. And of course, Dr. Nehal is managing the whole show very nicely. We are fortunate. And our president and secretary, they are providing this platform to learn. Thank you very much, all of you. Dr. Nehal, over to you.
Just a minute. I just want to share before Dr. Nehal takes over. Dr. Prajapati, it was last year that I was managing this particular platform on Saturday. But this year, since NNF Gujarat started the Wednesday platform, it became too difficult to manage both the platforms. So on Wednesday, we have our NNF Pathshala at 3:30 every time, and so it's a pleasure to come back on a Saturday and be an expert on something which Dr. Nehal is managing now. So it has been an extremely good learning experience, and I really enjoy these teaching sessions. And it's nice that I have had this opportunity with Dr. Naveen Jain, who was my examiner for my fellowship, just to mention again. But he has been very supportive of me in my endeavors over the last many times, and it's nice meeting with him. I just interacted with him about, I think, 2 weeks back in Ludhiana, and now again in an online platform. Thank you, Dr. Naveen, for coming for this, and thank you, AOP Gujarat, for this opportunity.
And all the best to all the students. You will make great teachers someday, sure.
Thank you, sir. Thank you, Naveen sir, and thank you, Somsekhar sir, for being there as an expert in this program. I thank Gunjali and all the residents who joined, and also Maulik sir for encouraging them. Even I request all the residents that whenever your case is ready and you want to present on the platform, just let me know. I thank Baldev sir for being there constantly. Thank you, sir. So we can close the session now.
Yeah.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you.
Thank you so much, ma'am, for giving all your time and making this session informative one. Thank you. With all your permission, I am closing here, ma'am.